Dr. Davis, please take the stage.
Hello, hi everyone. Thanks for joining so early this morning. I'm actually on a family vacation on the East Coast, so I'm usually on the West Coast and don't want to meet up super early. I'm gonna share my screen and can everyone see that?
Yes, it's perfect.
Okay, great. Yeah, so I just wanted to maybe give a bit of introduction about um, the Hereditary Spastic Paraplegia Center of Excellence at the University of Washington, where I'm located in Seattle, and give you guys a little bit of intro on who we are and what we're up to these days. And feel free to interrupt me anytime. Just want this to be very informal, and yeah, you can ask any questions. So, I want to give you first some of the people who are on our team. We're still kind of small, but these are kind of the major people that are working on HSP right now. So of course me, genetic counselor Emma Snyder, who's with me here at the AAN meeting a year ago in San Diego. They had some animals that they were um, sharing that we could pet. So anyway, we're here with this raccoon. But Emma is the genetic counselor who really helps me pretty much exclusively on HSP patients and um, helps diagnose most of the HSP patients that I see genetically, and then also provides genetic counseling. John Sanderson is a senior movement disorder fellow. We're hoping he's going to stay with us um, when he finishes fellowship in a year. He was a resident with us. He's actually from the Boston area, but we're hoping he can stay with us at the University of Washington. He is the PI for a pilot project that's funded by SPCERN that I'll talk about um, later on. Sarah Simon is our research coordinator. She has been focusing on um, the clinical research studies that I see, or that I am involved in, including SPCERN, the SPCERN pilot study. We have a HSP registry as well. And then Zoe Thomas just graduated from UW. She was working with us as a student. She's now staying on with us after graduation for a year while she is applying for medical school. She's also helping us with our clinical research studies, including SPCERN. So yeah, we are up here in the upper western corner of the U.S. Um, and this is the map from the SPCERN website that I'm sure you've seen. Yeah, for now, I think Norma, we don't have any other sites on the West Coast, right? Yeah. Yeah, so we're up there and
Yes,
we're
Marie,
kind
that's one of the things that, we don't have anybody else. These are the only ones that so far have been, associated. One of the things that I would really love to see is that there would be an affiliate type network so that you would be able to work with others on your East Coast that could understand the standards and the requirements. And then let's start kind of spider webbing, clinics and facilities knowledge basically across the United States.
yeah, and we were already doing that a bit through SPCERN, and even before SPCERN was existing, I was in touch with Dr. Darius Ibrahimi Fikari, and actually some of my patients were already going over to Boston to see him once a
Yeah,
year, and so now they're very happy that they don't have to do that anymore.
exactly, right? Yeah.
But yeah, so we're up there in the corner, and we're seeing a lot of patients. The interesting thing about the University of Washington is we have not only so UW is not only the only academic medical center in all of Washington state, but it's actually the only academic medical center in 5 states, and so that's why I put the whammy here. So
Whoa.
we actually see patients from all 5 states, Alaska,
Okay.
Wyoming, Montana, and Montana, in addition to all of Washington State. So I grew up on the East Coast, outside the DC area, and went to medical school at NYU in New York City, where the density of academic
Oh
medical
yeah,
centers very different. And when I went
very.
out to UW for residency, I was like astounded that that was that we had such a massive catchment area. I would also argue that for HSP, we really do see patients from Oregon as well, even though Oregon's not really it's not part of the WAMI, and Oregon has its own academic medical center, OHSU, but I'm do a lot of I collaborate a lot with OHSU movement disorder neurologists, and they actually send a lot of their HSP patients up to UW.
Great. I'd like to get the contact information from those folks too, Marie. That would be
Yeah,
fantastic.
yeah, absolutely, yeah. So yeah, and I stuck a picture of Mount Rainier up there. One of the my recent flights out of Seattle, we had just a great view. Um, So I want to give a little bit of history too on on the neurogenetics clinic at the University of Washington, and why we started seeing HSP patients, and why it's been such a it's such a focus for us. So this is Tom Bird here. Really started the UW Neurogenetics Clinic actually in 1974, when he was doing his medical genetics fellowship. So he had done residency at neurology residency at UW, and then he got into neurogenetics, really before it was ever a field, and it was pretty groundbreaking at the time. I mean, people just didn't think that that was, an actual um, sub kind of subspecialty of neurology that was worth focusing on. And he was really interested in um, especially Huntington's disease, because that was a very clear cut in identifying those families, but also genetic ataxias and HSPs as well. And of course, there's a lot of overlap with genetic ataxias as well. And so um, that he had followed HSP families for generations, ever since he started seeing these families. And but by the time that I started my residency, we were at that time, so that was in 2008, he was able to diagnose some people, but at that time it was really tough because you had to um, order, you know, genetic testing for one gene at a time. It was still done by Sanger sequencing, which is really time and labor intensive and very expensive. And so each gene was about two to $4,000 each. And I remember working with them in clinic as a resident, and we would just really um, think hard about which gene to order, because every single test was so much money, and of course insurance wasn't covering that, and so we would really try to think carefully about which gene to order. And then as I was in fellowship, and Tom Bird is still around. He's still doing lots of work, but he's only doing research. He's not seeing patients anymore. So he stopped seeing patients during my fellowship in 2013. And right around that time, we were starting to get next generation sequencing genetic panels, where you could order a whole panel of genes that were known to cause HSP. And that was about the same cost as what the single gene testing used to be, so about $2,000 to $4,000. And then some companies were had sponsored panels, and so we would take advantage of that. And so suddenly we were diagnosing a lot of, a lot of new HSP cases because we could send out this big panel, and we didn't have to worry as much about, oh, are we really going for the right gene the first time, And it was a really exciting. I mean, it's still very exciting, but that was a huge breakthrough. So anyway, I really um, do want to, yeah, thank Tom Bird for starting our neurogenetics clinic. This was a photo that I took at a 50th anniversary celebration because in 2026 I mean 2024, that was 50 years, which is really amazing.
Yeah.
And I'm sorry, next to me on the other side is Sumi Jayadev. Dr. Jayadev is also a neurologist who sees neurogenetics patients. She also sees some HSP patients, but she tends to focus on genetic dementias and Huntington's, and but she's also definitely an integral part of the clinic. I did also mention because in that map you can see that there's two little markers in Washington State, and that is because Seattle Children's is also up in Seattle, seeing the pediatric population of HSP patients. So I'm an adult neurologist. I really don't see anyone under 18 years old unless there's a really specific reason. Dr. Ming is how we she likes to go by as well. She is our movement disorder pediatric neurologist at Seattle Children's, who sees most of the HSP patients on the pediatric side. But I won't talk much about Seattle Children's. I'll let her hopefully maybe talk more about her site at another time.
That would be great. I would love to make a connection with her and see if she'd be interested in doing an SPF talks about the children's clinic there, and I can get those parents involved. That would be
Yeah,
wonderful. Thank you, Marie.
yeah, yeah, absolutely. And yeah, so so Dr. Ming and I do, yeah, we're always in contact. She has a bunch of patients that she kind of transfers to me when they become, past the age that that
Yes.
Seattle Children's wants to continue to see them. And sometimes that's as late as, 22 or 24,
Yeah.
but yeah,
Which is very important, but also important for our adult population as well.
yeah, yeah, absolutely. Yeah, so I pulled a little bit of numbers from our patients that are kind of established in our clinic, that have an established genetic diagnosis, and um, that I tend to see at least once a year. That I wanted it to say an N instead of a percentage, but basically when it's 3%, it's one patient. So,
Yeah.
um, but uh, our HSP patient population is, this is an adult population. So
Uh-huh.
we tend to have, of course, the most HSP type 4 patients, which is the most common one. HSP type 7 is our second most common. Our 5A patients, I only follow one, and it's probably because they get diagnosed, in childhood, and then, I think they may get followed more by rehab physicians or their community neurologists as adults, and that's something that we're working on and trying to get them more involved on the adult side. HSP 11 is also our kind of third most common, and then and HSP 31 or REAP 1 is also kind of a tie with our HSP 11. So yeah, we have of course, HSP is such a heterogeneous in terms of genetic causes, and this, really reflects that. And since we became a site for SPCERN, we are definitely getting more referrals from our, as we can tell, very large catchment area. So um, we're definitely, I didn't actually pull numbers on how we're growing, but we definitely are growing. And I also am not including here our kind of genetically undiagnosed but clinically um, HSP patients, which is harder to capture on our, electronic medical system. Um, but we definitely have a good percentage of those patients as well that we're working on trying to find the diagnosis. So I wanted to go into some of the things we're doing in terms of research studies. So this was a poster that uh, Emma Snyder, genetic counselor who I had mentioned, and John Sanderson, our movement disorder fellow, had presented at AN 2 years ago, so in 2025 in April in San Diego. And this was a case series of our HSP type 7 patients. So most of these patients are no longer living. These are patients that were seen by Dr. Bird as well as me. And so it was a total of 10 cases, which is a fair amount of HSP7 cases to have and be able to review. And we wanted to kind of see were there any kind of take-home points that we could glean from these 10 patients. I think the major one for me was that, oops, I meant to actually not have that around this column, but the other column, diagnostic, whoops, sorry, I put it on the wrong column. Highlight the diagnostic delay um, for this diagnosis. So it is 14.4 years was the average diagnostic delay, which is um, just, that's astounding. And that makes a lot of sense. I see this a lot. Actually, one of the patients was a 29-year delay. Another one was 27, 21. So the patients where it was a 1 year delay was where they had a sibling that was already diagnosed. And so then that was a quick, lead into them getting tested and diagnosed. So that is definitely something we have to work on. I mean, for an average of 14-year diagnostic delay is, absolutely not acceptable. And now, of course, with the next generation sequencing large panels, to be able to test people with for multiple genetic causes of HSP all at once is, of course, makes it much easier and is going to really be helpful in accelerating or reducing that diagnostic delay time. But that was very I think illuminating for me. Um, and uh, and then also the age of onset was very variable from the 20s all the way to the 50s. We already knew about this. Other case series or reviews have published a range from 11 to 72 years of age, but still it was interesting to see such a wide range. And of course, that is something else that we want to try to better understand. What are the factors that may be um, influencing that age of onset? Um, so then, yeah, that was just a case series. I just realized right when I was logging on, I forgot to include some other things that we've been doing. We did publish um, a case series as well, again for HSP type 11. Also included some of these patients that were included in this poster. But we had autopsy. Uh, we had neuropathologic um, studies done on two of the patients. So that was really illuminating in trying to better understand uh, this disease. Um, and I think, that's always kind of often the first kind of step to try to better understand the biological basis of diseases, especially in these rare conditions where not a ton of people have it. Because, yeah, we just, we can't generalize, and we can't have, a ton of data, and having that neuropathologic data can just be really, really illuminating, trying to understand exactly what's causing the clinical symptoms, and what might be the biological basis for those symptoms. That was really, I think, what Tom Bird really that was, I think, how he was able to make so much progress in neurogenetics. I mean, he was seeing, as I said, seeing neurogenetic patients before we had genetic testing for these conditions, and he was able to gain a lot of insight, just based on neuropath studies. It's it's unfortunate because, of course, we can't do neuropath studies until people pass away, but um, and so it's obviously not the best, not the best way to try, or not the best way to help people, when during their lifetimes. But that's not what I meant. But it's just, we can gain a lot, but it's only at kind of the end stage of, we gain insight at the end stage. So, of course, animal models, cell culture models are we're starting to gain a lot more insight from those. But um, but anyways, that's a whole debate. But I think his studies have really gained a lot of insight, um, and I think the University of Washington has a great neuropath department, and so we've had this close collaboration that has also allowed us to do a lot of um, studies. So our current studies at the University of Washington, uh, as most of you know, we're a site for SPCERN, the Natural History Longitudinal Study that was really started with pilot funding through SPF, that was groundbreaking, and then followed by NIH funding that we received last year, and has allowed us to really, further grow and expand this study. And so I wasn't actually going to talk much about that, Norma, because I know, I'm sure Dr. Dr. Darius is going to talk about that at some point, and so I wasn't going to talk too much about that. If that's
No, and
okay.
that's fine. That's fine, Dr. Davis. No, no issue at all. So that's a whole different type of presentation that I was hoping to hear from today, not the hardcore science about that particular manuscript, but you've said so many things that have already been just resonates with what's going on. But and trying to get to a point of how do we get the assistance, and I guess what I was really more interested in, and our population may have a different perspective, but if I want to register and be a part of this clinical trial that you've got going on, because you're doing a clinical research study in your facility with HSP patients. So
Mhm.
if I am in your vicinity, 5-state area, let's say, or beyond, what would be the process? What would take place as I am coming in as a patient?
Yeah. So one way, actually, one way to do that is through, let me see.
Which probably is the same procedures at all the other CERN locations as well.
Yeah, is to contact our research coordinators, or so Sarah Simon or Zoe Thomas. Um, is kind of one easy way to reach out to us. I should have put our clinic coordinator, Debbie Olson, for the neurogenetics clinic. She's also uh, kind of the first person people often contact to get in touch with us. And I can put that in the chat. Let's see.
That would be good.
Excuse the
Three.
interruption. Is this study just on HSP7 or all HSPs?
Oh, so that was just the study I showed, that was the poster presentation. That was just a clinical case series that we had done as a poster. It's not an ongoing study right now, but I will show you a pilot project that we are doing through SPCERN that is looking at using non-invasive spinal cord stimulation to try to treat HSP. And that's for any HSP actually. Hold on one second. Let me put Debbie Olson's, sorry, so she's our clinic coordinator at the neurogenetics clinic in at UW, and her phone, let me grab her phone number. Oh, actually,
Hey, Dr. Davis, you can send that to us as an email as a follow-up, so
oh,
you don't have to work too hard at doing that now.
okay, okay. Yeah, I'll send you her fax number. I never remember it offhand. Um, but we get referrals all the time um, for uh, from so people will often have their primary care doctor send in a referral to Debbie, and
Okay,
then
good to know.
yeah, I will warn you, I do have a long wait time right now. It's terrible. We're
Yeah.
hoping that maybe Dr. Sanderson can join me in clinic once he finishes fellowship and be able to help out with that.
Yeah.
um,
Well, and that's like one of the things that I was saying. If there's a way that you can look at, within a structure, in a radius, that these other clinics and locations, these therapy centers, maybe they could
oops.
be some of that basic intake, that
Mhm.
they can get some of that information and get some of that started with these patients.
Yeah, absolutely.
Because we see this growing. We're seeing an uptick in patients that are being diagnosed with HSP and PLS. So
Yeah.
it's coming fast, and we need to be, trying to find ways to be, available and accessible to everybody.
Right. And I think the fact that there is more we can offer now in terms of studies
Yeah.
is getting people out. Because uh, I mean, I've heard from patients themselves say, well, I was diagnosed and then I was told, there's nothing you can do. And so what's the point? What's the point of traveling all the way to another state to see to go to a clinic appointment where people aren't giving me much? And
Yeah, and that's
absolutely.
really the hardest part is a lot of our doctors across the nation don't really understand the mechanisms that are happening with people with HSP and PLS because they've never seen them. And
Right.
so, when patients are going into them and they're trying to explain this is what's happening to my body, all they're getting back, and maybe not all, but what they're getting back is well, it's just kind of in your head, and you need to do this and this and this, and those things are not helping at all. And we've
Yeah.
got to find ways to be a little bit more educating to our locations across the nation that are seeing patients. And I think that would be a great educational help, using the CERN as the network to help train our patients' doctors, if nothing else.
Mhm.
And we've got a comprehensive list, and that list is being added to every day. And some of those doctors don't really understand, but that patient's going there, so that's as close as
Right.
they can go, so we still need to try to find ways to educate the educator.
Right. And that nearly 15-year delay in diagnosis
Yeah.
totally reflects that, and that's at the University of Washington.
Oh,
That's
it's
not.
everywhere because we
Yeah.
still have patience, and Miss Jackie's been waiting so patiently to ask you a question. But
Oh,
even
sorry.
Jackie,
I'm sorry.
she is, SPG unknown, and that is a total population of people that, we have in our database, and we're still searching for things that can help them be diagnosed.
But
And I don't know.
I guess I still, Dr. Zuckner told me I'm still in the SP CERN study because he's working on my blood.
Yeah, right. We still are discovering new genetic causes for sure. And yeah, I've got families where it's really clear that they have HSP, but they've tested negative for, all the known genetic causes. So there's definitely still, we're still learning new genetic causes. I know it's unfortunate to be in that situation though. You just want that, you want to know exactly what the cause is for sure. Sorry, I
Jackie,
haven't.
did you have
Uh,
another question though,
Yeah,
Jackie?
I have two questions. On
yeah,
Okay. Is
the
that okay with
pie
you, Dr. Davis?
yeah,
Okay.
absolutely.
on the pie chart you had X dash ALD. What's that?
Oh, I included X linked adrenoleukodystrophy, which isn't officially considered an HSP, but sorry. But
That's okay.
it has a lot of so the adult actually it shouldn't really be X, it should really be X-linked adrenomyeloneuropathy. It is also genetic, X-linked. It's but women can also have develop it as well. There are female carriers that have it. It's a adult onset, and it looks almost identical to HSP phenotypes.
Okay.
The childhood
Then
onset is very different, but
the other question was you were mentioning Seattle Children's Hospital, and who should we reach out to there?
so that would be Dr. Ming, and I'm
I
not
got the
sure.
Ming written down, but it was Ming's a whole bunch of other letters, and I
I
didn't get all
know.
that.
Yeah,
I
Jackie,
know.
I've got all that, and we'll have this available on the YouTube channel. So we will reach out to her and make sure that we've got that information connected on
Okay.
our website.
Okay.
I know she has a very long name. And she has a research coordinator. She has at least one, and I'm not sure who it currently is. So I didn't put it on here, but um yeah, great question. Please feel free to interrupt me. Sorry, I didn't have the chat up and I didn't see the questions. I don't know. Were there any other questions in the chat?
No, I don't think so.
Oh,
Well,
okay.
somebody did ask about where's the CERN in New Jersey. So that again, that
Oh,
information you can find on our website. Go ahead, Dr.
um,
Davis.
sure. So I wanted to tell you about a pilot project um, that we just recently got pilot funding from through SPCERN, and we're just about to start. Also want to mention we have a local registry, so a registry just at the University of Washington for our HSP patients, and this is basically allows us to reach out when we have a new clinical study where someone might be eligible for it. So we're ready. We've got everybody kind of ready to go to recruit for new clinical studies. So for the spinal cord stimulation pilot project, I want to give you some background on where this came from. So it came from uh, a basic researcher at the University of Washington in the Department of Rehab Medicine who has been developing transcutaneous, so non-invasive spinal cord stimulation um, that he first started using to treat traumatic spinal cord injury patients. And this is a really short video about that use of it in just in spinal cord injury, but I wanted to show you. Oh no, I was hoping this one. Oh, just trying to put in this link. And what I could do is stop sharing and switch to.
Dr. Davis, while you're doing that, let me ask you, this pilot grant that you've received, is this also available at the other CERN locations?
No, not
Okay, so only
not
your
not for now.
clinic is doing this. Okay.
Right. We're hoping that if the results are positive, then we can get funding for, a much larger study that's multi-site. Actually, or even just a larger study, even at our site, because right now the pilot funding is going to only fund for um, 4 participants. So I know that's really small, but we have to start somewhere.
Of course,
Yeah.
and definitely, I think there's already that type of research that's going on. We have already, the foundation helped to fund a Brazilian study that has 300 patients in it, and then Dr. Sesteva with the University of Kentucky is doing another study, and I'm not sure at this point how many people are in that study. But this technology, I think we're going to find is going to be very helpful. And I would like to see that this type of technology is available in every physical therapy office across the nation.
Yeah. And actually, so Dr. Moritz has also developed a home therapy, so
Yes,
that's even better.
that is even better.
Can you see what do you guys see on your screen right now?
I see your presentation with your slide deck onto the side.
Okay.
Now it's unsharing. I see you.
Okay. Let me get that
Technology,
YouTube.
it's a love-hate. You just got to go with it and flow with it, right,
I
guys?
don't know. Sharing. Yeah.
I appreciate all of you guys staying with us this morning and learning and hearing and seeing things, because
Oh,
there's a lot of information that we're throwing at you, and you think, well, why is this relevant? Why does this matter to me? Because if you've got HSP or PLS, then this conversation matters to you. You may not know it yet. And if you have questions or concerns or thoughts, I beg you to re-watch the YouTube channel. And then if you have questions, do a quick AI search on certain words that you don't understand. And then if you have questions, you reach out to me and we'll talk about it. How's that? Is that fair? All right, everybody. Go ahead, Doctor. I'm just giving you time to set your technology
yeah.
up.
Do you see
The
this
YouTube channel, I do. We
yeah.
see YouTube.
Okay.
Yeah.
Okay, let's see. Let's see.
Hit the
Okay.
play, hit the expand, and it should take over.
Is that good? Yeah.
We haven't seen anything move yet.
Oh no.
Okay, wait a minute.
Okay.
We're back to you
Oops.
now,
Oops.
commentary.
Um, it's okay. Maybe I'll let you guys watch. Oops. What am I? I'll let you guys watch that video, maybe that 2-minute video. It's basically showing um, the non-invasive spinal cord stimulation and how it's working on traumatic spinal cord injury. And that is basically the basis of our pilot study. We are wanting to apply that technology and see if it helps HSP patients, because HSP is kind of like a genetic progressive spinal cord injury.
Yes.
And actually, I'm actually a full-time VA employee at the Seattle VA, actually.
Oh,
And the VA in Seattle has a spinal cord injury unit, and they accept HSP patients as, part of their SCI patients. So yeah, no, it's
that's
awesome.
fantastic. I'm so
It's
glad to hear
awesome.
that.
I
That's
send,
fantastic.
I wish all of my HSP patients were veterans and I could send them there because they do such an amazing job. Um, but so yeah, so we want to see if this technology can be just as effective in HSP patients. I wish I definitely watch that video because it's amazing. This woman, had a high cervical traumatic spinal cord injury and was um, really not able to use her arms. She's wheelchair bound, and you can see that she's able to use her arms in meaningful ways after using the spinal cord stimulation.
I am very convinced, doctor, that the things that these patients are going to be needing in their care is really going to be like multi-pronged. And I really believe that this type of stimulation is going to have to figure its way into the therapies that our patients are living with right now. There
Yeah.
may be a molecule, there may be an enzyme that you'll have to take every morning, like you do, your vitamin or whatever, and then go to the clinic or have this technology available in your home so that it can help re-stimulate and regrow what has been damaged, or find a workaround, right?
Yeah, yeah. And the great thing is Dr. Moritz has already gotten this FDA approved for traumatic spinal cord injury. And so there's already a precedence, and hopefully if we can show that it's helpful for HSP patients, we already have a roadmap to get it FDA approved.
That is fantastic. I'm so glad to hear that about Dr. Moritz. That is wonderful.
Yes, yeah, no, he's been amazing. So in terms of HSP, there are already studies that have suggested that this can be a very helpful therapy for HSP. They're all pretty small studies, case reports. There's also more invasive spinal cord stimulation where the stimulation is placed, inside the body, in the epidural space versus uh, outside of the body. What we are going to test is a non-invasive, so it's like like a sticker that you put on your lower back. It's not anything that's surgically implanted. Again, that's something that you can see in that YouTube video. So sorry, I'm having trouble with that. And this is going into the weeds a little bit, but basically, Dr. Moritz has developed a stimulation that can better basically go through the skin that's not painful and better stimulate the spinal cord. So sorry, I guess I'm not in presenter mode.
That's okay.
There we go. All right. So we tested this on two people, two of our patients, uh, before we submitted our proposal in at I think it was early February. We got these two patients in right after the holidays. It was really impressive that they were able to do this, but I guess it also shows how motivated our HSP patients are for any new therapies. They only had the stimulation for 5 days. It was 5 days in a row, every day for about an hour plus, or with intensive physical therapy. So that's the thing. It's not just the stimulation alone, but it's done in combination with intensive physical therapy. And we just, wanted to see if we could get any positive response. And actually, we got a very positive response. So this is our two patients, and we looked at basically strength. So this is, basically just a way to quantify strength in different muscles: hip flexion, knee extension, ankle dorsiflexion. So bringing your toes up um, and then pushing down on the gas. And there was in one of our patients, 180% basically improvement in strength in those muscle groups in the lower body. And then the second patient had 78% improvement. And then, of course, we wanted to look at spasticity, and we do see a decline in spasticity. It is a pretty short time period, so we weren't even sure if we were going to see anything, but we actually did see a trend downwards. It wasn't significantly, like statistically significant, but of course, this is just 5 days. So we were really happy just to see this.
Yeah, that's remarkable.
Yeah, yeah. No, it was really, oops, one more thing. Yeah, this was another way to measure overall kind of mobility in our HSP patients in this scale called the SPRS, Spasticity Paraplegia Rating Scale. And again, you can see that there was a decrease in that overall scale score in both of our patients. So oops,
And these are
sorry.
both adults, right?
Yes, yes, sorry. Oops, I got lost again. Oh, I missed this slide. Sorry. This was looking at a timed walk test, and you can see that there was quite a significant improvement in the speed of walking. So both of the patients that we um, uh, that participated in this really preliminary test, they were both walker dependent at baseline, and you will see I have a video of uh, our participant who had the most dramatic improvement. Um, so again, yeah, this was the
The
overall kind of,
scales that everybody has
yeah,
to go by. So you guys
right.
see this SPRS, SPRS, SPRS. That is a rating scale that talks
Mm,
about your progression of movement. So these
yeah, and it
doctors
kind of,
all have to have something like this about you.
right, and it takes into account kind of a lot of different aspects of the disease, overall mobility, spasticity, strength, even bowel bladder, and
Yep, those are
pain.
issues. Those are concerns.
Yeah, yeah, and so it's a little bit more of a kind of a holistic view of the HSP symptoms. So hopefully this will work. So this was our participant who um, had the biggest improvement. This is Chint in the corner here. So this was before stimulation with his walker.
Everybody watching?
And this is at the Gate Lab at the University of Washington.
Yeah, thumbs up.
So you can see he, has the very typical foot drop that makes it hard to clear his feet. Kind of slower speed. And this is after. This is during stimulation, so he's not using a walker. Um, it's
We
a
all
lot.
remember those days.
It's a lot better. And then this is after 5 days, and you can
After
see that.
5 days of that, oh
Yes.
my goodness, isn't
And so
that
he's not,
wonderful?
yeah, he's not using the walker, and he's
Yay!
practically, the research coordinators are practically running next to him. So one more, yeah, he is really going fast. So that was an amazing, and so that was just 5 days. Obviously, we want to test people for longer than 5 days.
Yeah.
Um, but yeah, we needed the funding.
Yeah.
So
Well,
thank you.
and one of the things that I really love, I want to just encourage the population to understand the impact that's going on here. Dr. Franca in Brazil, he actually got a young man out of the wheelchair using this technology. And you can find that SPF Talks on our YouTube channel already. That was last year. So this
That's
technology is absolutely phenomenal in being able to help people. Is it the cure all, the end all? No, it's a piece of the toolkit. And you need to understand, where does this fit into my therapy plan? So it's a piece of the toolkit. Thank
right.
you so
And
much, Dr. Davis, for helping show all that. That's remarkable.
yeah, no, we're really excited. So we're the pilot study that's now funded that we're just about to start with. Unfortunately we're only able to enroll 4 people right now.
Right.
These are kind of the the things that we're looking for is someone who is a established genetic diagnosis. We want people who are still able to walk. It can be with a walker, but right now we're not testing people who are already wheelchair bound. Just to be able to use those rating skills and be able to kind of see the difference at kind of maximum effect.
And to really get to the point where to really, you guys get to the point, and correct me if I'm wrong, Marie, that we can get FDA to approve this as a therapy for HSP PLS. That's what, you got to take these baby steps. That's why funding is so important. That's why we at the foundation are always saying, donate when you can, give when you can, because see, as you're hearing from her, this is where she's at. She can only study 4, and we've got to have more than that in order to put together this information for FDA. So, but I think if we pull the pieces together, then we've got the whole that we need. So thank you,
Exactly.
Marie. That is so important to distinguish.
Yeah, and these 4 data from these 4 patients are going to be the basis for a much bigger study where we can hopefully then, with that bigger study try to get FDA approval.
Well,
Um,
there's a question in the chat
oh,
on the screen. Miss Barbara's got a question if you don't mind taking that.
oh yeah, sure. Yeah.
Go ahead, Barbara.
So I have two questions. One, do you envision this as a long-term therapy that if it's successful, if you keep doing it, you'll have those results? Or do you see it as, or a possibility that it could retrain? This therapy can kind of retrain the way your upper motor neurons are being transmitted. And then my second
Mhm.
question is, the commonality of HSP is the lower leg spasticity, but then there are the more complex versions that, the ataxia, bladder dysfunction, sexual dysfunction. Do you envision going to another tier of research to see if it will work on the more complex symptoms as well?
Yeah, those are great questions. And so in terms of the long-term effectiveness of this therapy, hard to know yet, but from the spinal cord injury patients who have already, been using it for a little bit of time now, it does seem to be a long-lived benefit. But people are using the stimulation on a at least weekly basis, and then doing physical therapy as well. So it's but it does seem to have you know a long-term benefit, not just a short term, and then whether it's actually remodeling to change the course of the disease, we don't know yet. It does definitely seem to have some of that effect in the spinal cord injury patients, so we're hopeful for HSP, but it's hard to know. I mean, with spinal cord injury, it's like a one-time trauma. It's not as much of a kind of progressive degenerative condition. So it's going to be probably something different with HSP, and we'll have to see. And then, sorry, second question was
Oh, the more
second.
complex,
Yes,
it's
more
outside the lower leg.
right. So actually, with the spinal cord injury patients, they do see some benefit with bladder symptoms and with autonomic kind of dysfunction, autonomic dysreflexia that happens with spinal cord injuries, and that we see in HSP as well. Uh, in terms of like the kind of more complex one, HSPs where there can be, ataxia, more, cerebellar dysfunction, intellectual disability. That's probably gonna, I suspect, not gonna be as improved by this therapy, but we'll have to see.
If I can add a little bit there, Barbara, I see it as a means that and again, Dr. Fink always says, well, it may apply, it may not apply. Okay. So always listen to that first. For some of the HSPs, like let's say the ones that have mitochondria dysfunction, it's not going to fix the part that is wrong. The lysosomal dysfunction, it's not going to fix that. So that's going to continue to progress. But, is the stimulation going to be beneficial for all the other stuff that your body may still be dealing with? If you can handle that, then more than likely, absolutely. I mean, they've already been doing this on the cerebral palsy patients, and they've got clear help in understanding that clinical trial and what's going on there. So that's the kind of thing that's hard to understand. There's going to probably be a molecule that's going to help the degeneration, and maybe a molecule that's going to help the regeneration, and then the stimulation to get you out of the wheelchair. Think of it, kind of like a pronged, three-pronged approach.
Yeah, and I just want to, so I see Parkinson's patients as well, and we've had deep brain stimulation for, I think it's been now about almost 3 decades now. And so we know that DBS is not changing the course of the disease. It's not stopping the degenerative part of Parkinson's, even though it can really significantly improve symptoms. And so I suspect that this will be kind of similar in the way that it fits in with people's treatment and therapy plan, as similar to how DBS is used in Parkinson's, but hard to know yet. Jackie, I see your hands up. Oh, I think you're still muted.
Oops. Can somebody have spinal cord stimulation if they've got metal in their back, like fusions?
Right, good point, because that's really common in even
It
just general population. Yeah, to have lower back.
you
Yeah,
can still have it.
I don't know actually. That's a great question. And so yeah, I'm not sure.
And
I'm
I'm
not sure.
also wondering, I've got the inner stem,
Mm-hmm.
and I'm
Yes.
wondering if my low my lower half of my body is full of metal.
Uh-huh. Yeah, I don't think that it can be used at this point with another stimulation device. Like if you have a pacemaker, if you have so if it's implanted, yeah, I'm at this point, I think that's
Well, if I could have spinal cord stimulation, I'd yank out the bladder thing, because you said it helps bladders, right?
it's so far it looks like it's been helpful, but that's still being
Okay.
evaluated.
Hey, you guys, I know there's a lot of questions in the chat box that probably we need to have another conversation about this. So we're probably not going to be able to get to all the questions. So if you guys will hold those back, we're already 7 minutes over time for this hour's presentation. And we certainly want to respect Maria's time and her work and effort and all the things that she's doing. Always there's questions. Always there's things that, we want to talk about. So bring you guys questions back to the table. We have open forum on Thursday night, and I would love to see your faces and us have, pick up some of these questions and conversations along the way. Marie, I want to give you whatever time you need to finish up, and I'll stay longer, but I want to respect your time, dear, and thank you so much for being here.
Yeah, no problem. I guess the last thing I wanted to mention about our pilot study is all four of the participants are going to get the stimulation. It's just that they will be blinded to whether they're getting a sham, like kind of a fake stimulation, but versus the one that we want to test, the kind of real stimulation that we want to test. So unlike kind of the typical, blinded, placebo controlled. This is placebo controlled, but everybody's going to get both the placebo and the real simulation. Because if we had 2 and 2, that would just not be enough people to test at all. So, and we hope to be able to continue that, in larger studies so that there won't be people who aren't getting any stimulation at all.
Gotcha.
I know that's always a concern, like you don't want to be in the placebo group that doesn't get treated. And so yeah, the PI for this study, as I mentioned, is Dr. Sanderson. He's our senior movement disorder fellow, but he is a really up and coming star. And this is going to be in combination with Dr. Inanichi, who's been working with Chet Moritz on the spinal cord injury patients with and then also the cerebral palsy patients, as Norma mentioned, and they've also been testing it on stroke patients. So Fatma is, really integral to continuing to expand the use of this technology. And of course, Dr. Moritz. We have some rehab medicine fellows who are fellows in spinal cord injury who are going to be helping us with doing all the clinical ratings, and a physical therapist, PhD, and then of course our research coordinator. So I think that was basically it. Yeah, that was all I had. So
That was a wonderful presentation, and I so appreciate you very much, Marie.
yeah,
It's been great to meet you and to talk with you and to be on this journey, because I usually see you on all the monthly CERN meetings.
yeah,
And I also want to share with the group that because the CERN organization was formed with the NIH, we are also the patient advocacy organization that works with this group and NIH. Thank you so much. I appreciate your help today. You have a great
yeah.
afternoon.
Thanks. Bye.
Thank you for all your work. Goodbye.
Thank you.